we'll start. And Bobby, I think you're representing the only clinic that's not a partner here, so welcome. It's for you that we want to do this, and for others who may join in
Perfect, thank you.
at a later time. So thank you. And Dr. Blount, welcome. So I'm going to briefly introduce what we're about. That the partners are a network of clinics that are identified and recognized for providing services that positively impact the health of people with spina bifida. And I think no one would argue with the value of the standards as they're written. They might need to be clearer. Did somebody say something? Okay. And clinic care partners are knowledgeable and experienced healthcare professionals who collaborate with SBA and other spina bifida activities in their communities nationally. And what we're about is ensuring that the best care and support and information is provided to people with spina bifida. So Jeff's going to introduce standard 1, and each slide is going to have the standard, the rationale, the documentation, and we ask that you introduce yourself and then talk about the value of the standard and how you have implemented it, or in your application, how you implemented it. Okay, Denise, can you hear? Denise said can't hear anything. Can you all hear me?
Yes.
Okay.
Yes.
Okay, Denise, I don't know what's wrong.
Denise, all I see is, all I see for you is just only your video is on. And so you might need to adjust your audio settings, and sometimes you can do that through your control panel. If there might be a button to join audio.
And y'all, I didn't say this, but if you have any questions or comments, put them in the chat box. Use the chat button to do that. Can you hear yet, Denise?
I can hear you. Judy, can you hear me?
Yes,
Yeah.
great, thank you.
Okay, perfect. Sorry, this takes me forever.
Okay, Jeff.
Great. So the guidelines were developed, some time ago. There were actually 2 parallel sets of guidelines developed. The Spina Bifida Association one was, I think, by far the most practical one, and I think everybody's quite aware with the process that occurred, that we brought together people, stakeholders, if you will, people with expertise, people with experience, to a series of meetings whereby we flushed out what some of the active issues were, what some of the active questions were, and tried to, put those in a way that was meaningful clinically, but that was germane to the person, if you will, in the trenches, right? The person in the clinic space trying to deal with a challenging problem. And the challenging problem, that was one of the places where we wrestled a little bit, because the challenging problem, of course, in this disease can run from the elementary to the really ultra complex. And so that was one of the challenges that we had as far as trying to put this together. So in terms of trying to, build on this, we tried to put together a series of guidelines that called upon best available evidence. We did very careful with the help of Judy and Tim and Brad and some medical librarians. We did very careful evidence-based reviews, and we were diligent in applying that, but not handcuffed to it, by which I mean the other process of the worked on guidelines at a similar time ended up a little bit more handcuffed to evidence-based medicine, which is to say, we can only talk about things for which we've got not perfect, but great evidence. And the medical literature is an imperfect thing. And so as a result, we didn't end up answering some of the practical questions that the SBA guidelines did. The SBA guidelines were put together in an effort of trying to come up with something that was practical, that was evidence-based, and called upon experts in the field of how to do it. Now, pivot from the genesis of how they occurred to kind of how we try and implement them now. I cover 2 clinics in spina bifida, pediatric here at Children's of Alabama, adult up the street at UAB. So how do we implement, what the guidelines suggest that we do. Well, I think it's an ongoing active dialogue. It's an ongoing active discussion where some of our preferences were very much modulated by what we see in the guidelines. We became aware by reading and implementing the guidelines that some of our specific individual, probably more bias-laden practice preferences weren't ideal across the board. They weren't things that our partners, that our colleagues who also had big experience, and most importantly, that the literature necessarily supported. So I would say for us, it was largely a matter of modulating what we did, being aware of how the guidelines were, came together. Judy, how else can I provide support and examples of this?
What would you recommend as in the application, how to document how the guidelines are being used?
Well, I think that the examples of how the guidelines are being used, ours is, in a sense, everything stems from the guidelines for us. In a sense, because we thought that they were so important as far as the way that they were developed. Literally, you can almost walk through it temporally from the time a baby is born, the elements of care, the timing of intervention, the choices and thresholds for triggering. Do we intervene for hydrocephalus? Do we use a shunt or do we use an ETV CPC? We try and get that back closed within 48 hours. Choices of antibiotics, don't use antibiotics. There's a great consensus. I'm a neurosurgeon. There's a great consensus amongst the neurosurgeons surrounding the guidelines that were used. Now, when we get to the adult world, it's less clear cut, and there's a lot more preference-driven care. So the things that were present in the guidelines there, as far as the implementation, as far as timing of follow-up, as far as the role for different services, we've incorporated the use of the guidelines in our adult clinic quite carefully, as far as how frequently people come, how frequently they get urodynamics, how frequently they get other KUBs and renal ultrasounds and things of that nature.
Thank you. Thank you. Anybody have any questions? Current partners or new interested partners for Jeff or others about the guidelines and this standard? Okay. Thank you, Jeff. Thank you very much. Kathy Smith is going to talk about standards 2, 3, and 4.
Okay, thank you. So the first standard is, standard 2 is the fact that you need to have a medical director from a medical or surgical discipline. And if the medical director has a surgical background, the clinic has to demonstrate partnership with providers from a medicine area, physiatry, general pediatrics, etc. And the purpose of that is to ensure the ability to really look at the whole child and in a comprehensive way, recognizing that many organ systems are involved with the condition and the condition impacts many areas of life. So a comprehensive view is very important. You provide the CV of the medical director with your application. Our medical director happens to be a general pediatrician, and then we have a number of other specialties that I'll tell you about in the subsequent standards.
So Jeff, you're the medical director at, okay. And then you tell us how you have other general practitioners. Oh, you're muted.
Oh, you muted me. So yeah, I serve as the medical director, but that's more of an administrative thing. Ours is very collegial, right? Our director of rehab, Drew Davis, very actively involved. Our senior person in urology, very quiet person, David Joseph, but very senior, very experienced. So this is very much of a collegial thing. And for us, that works very, very well. I would be happy to call any of them the medical director. And I think that this notion of collaborative collegial care in a sense, the Spina Bifida clinic can and ideally ought to be the epitome of that. I recognize it can't be that way every place. I've learned a lot about these clinics largely through SBA meetings, and I'm grateful for that opportunity because my hat is really off to people that make a Spina Bifida clinic work when they don't necessarily have everybody that can come to the same table at the same time, right? There's a lot of different recipes for this, and it works in a variety of different ways because the providers and their associated teams are committed to making it work. And I would submit that the most important elements are commitment to those kids and families and commitment to ongoing communication to your partners and friends. No matter how hard or how big your center or whatever is, communication always, always, always is the biggest challenge. I walked out of our clinic last week going, oh, I wish I could get everybody in a modern era to be able to stop at the end of clinic. And we run our list at 3:30. That doesn't mean that's what you have to do or everybody needs to do that. But we implemented that a couple of years ago so that everybody could hear what everybody else was thinking. But that's very much of an ideal. And it's not as real and as granular as I want it to be. In my perfect world where I'm made czar and I get to move everybody around like chess pieces, everybody stops what they're doing. We sit down, we have a cup of coffee at 3:30 or 4 o'clock and pays attention. Hey gang, guess what? It doesn't work that way. It doesn't work that way at UAB. I don't think it works that way at most places. We have a meeting, we run the list, but it's a little bit of organized chaos because some people are still seeing patients, some people are making phone calls, some people are coming and going, whatnot. So bottom line, communication, number one. Your medical director can be from any background, and it's commitment to communication that I think is most important.
Standard 3.
So let me just add that in our clinic, we have, for our program, we have 2 co-directors, myself and Alex Van Spabrock. And Alex is also the medical director of the program. So for our clinic team, we have a very, very large clinical team, including Alex, the medical director. We have a total of 5 pediatricians who come to clinic. And we also have a physician who's an adolescent medicine specialist. We have 2 nurses present in clinic, as well as a nurse who serves as a transition specialist. We have social work, OT, PT, dietitian, orthotics, urology, ortho, trying to remember who I see wandering around. But it's a very, very busy clinic. For OT and PT, we have several each of those disciplines. So that means it's a large number of people to coordinate during the clinical time. So the way we do it is we have the 2 nurses present, as I said, in clinic, and we have a centralized place where we track who needs to be seen by which disciplines, etc. And one nurse stays in that central place. So all disciplines come into her to talk about who needs to be seen. And we also have wound care. So for instance, if PT identifies that a brace is causing wound issues, that comes back to this centralized nurse who then assures that the wound care nurse sees the child during clinic. The second nurse is the one who's out in the clinic doing her nursing assessments with each patient. So that's how we kind of organize our clinical activity. To Dr. Blount's point, it's kind of hard to keep track of everything when you have so many patients and so many moving parts. And so for us, this has been the easiest way to do it, to have this centralized nurse who serves as the communication hub for everybody, tracks what's happening, and then the other nurse who's out doing the nursing assessments and doing patient teaching. And I agree with Dr. Blount completely about the need to communicate. The way we do that in our program is we have a once a month administrative meeting. It's about 8 of us who serve as the core of the clinic. And then 3 times a year, we have an all program center meeting. And in fact, we're going to have our meeting this Friday, our program wide meeting. So if we consider all the specialists, et cetera, who are available as part of our team, then we have probably 60 people who are represented in the Spina Bifida program, who get invitations to the 3 times a year meeting. We have all disciplines represented actually in clinic, with the exception of neurosurgery, who's available to us by consultation. And they are super collaborative and super helpful. And even though they're not physically present in clinic each week, they are very responsive to taking care of our patients and families. So we recognize that the multidisciplinary model has really been long recommended in order to meet the needs of the population. And actually, our state Title V program for children with special healthcare needs, which is called California Children's Services, requires that patients with spina bifida who are served by that program have to be served in a multidisciplinary special care center. So we wouldn't even be able to provide care for these patients in the CCS program if we didn't use this model. And so in order to demonstrate achievement of the standard, you provide a written description of the spina bifida clinic care team with their names and credentials.
And so just to note that the minimum standard for this is that there's a medical director and a nurse or a nurse practitioner. And everybody will have some members of the team, but as Kathy said, they access, for instance, neurosurgery in a certain kind of way that's not as present as some of the other disciplines. And that's a departure from, as this says, from the multidisciplinary model being the only way to provide spina bifida care.
Yeah, I think that the really important consideration, if your disciplines cannot be physically present in clinic, is that you have a good means of communication with them about the patients. And our neurosurgery program has nurse care managers. We have nurse care managers. So there's a lot of communication that happens back and forth. So we feel fairly confident that none of our neurosurgery needs fall through the cracks as a result of this. So we feel confident about it. So standard 4, the team collaborates with all of the identified subspecialists that are required. For us, most of these folks actually come to clinic, like I told you, orthopedic surgery, urology, the OT and PTs, nephrologists, GIA and GI are available to us by consultation. And then we have dietitians who are also with us in clinic. We have, not unlike other clinics, we have a pretty significant obesity problem among our population. So having the dietitians present for every clinic is really important to us. And we actually have 2 that come to clinic. And, consistent with the philosophy of our Title V Children with Special Healthcare Needs program, we believe that all of these disciplines should be available to the families in a centralized way in order to make their lives easier, honestly. And in addition, to be able to coordinate with each other. If our patients had to come back and forth to see all these different specialists on a regular basis, I'm not sure they'd spend much time in school because we'd be having them come back and forth to the clinic so often. So it's really, and we try to book our patients so that they're seeing all the specialists that they need at the same time, so they're not having to come back on separate days. So the rationale for this collaboration is that it allows for multiple specialists and generalists and other allied health professionals to address in a coordinated way the needs of the patients.
Okay, thank you, Kathy. Before Colleen talks about Standard 5, which is care coordination, I want to note that when we first announced the Clinic Care Partner Program, this was the standard that we had to ask for more clarification than on any other. So so we changed the standard a bit. After Colleen talks, I'll say that. But we're really, really committed to care. SBA is committed to care coordination. And I know Colleen's going to do a good job of talking about it. And that's why we asked her to talk about it. So Colleen.
Thank you. Hi, everybody. So I'm Colleen Rosen. I am the nurse practitioner in the Division of Neurosurgery at Lurie Children's Hospital. And I'm also our program coordinator for the Spina Bifida program. And so for us, what care coordination looks like, so our multidisciplinary Spina Bifida Center, we offer coordinated individualized care for every patient. So we have the dedicated personnel who are available 5 days a week during normal business hours. And who is included in that list is our program director, Dr. Bowman, myself. We have dedicated Spina Bifida nurses and research staff who are available 5 days a week. And then we have an administrative coordinator and a scheduling liaison who are also available Monday through Friday during normal business hours. And so that is kind of our core team that we identify as our the care coordination core team. Then let's see, just moving right along. So what we do from our perspective, so our clinic meets weekly. We meet every Tuesday, and similar to the other clinics that have been discussed, our clinic, it is neurosurgery, urology, orthopedic surgery, physical medicine and rehabilitation, physical, speech and occupational therapy, social work, and we have a resource specialist, pediatrics, psychology, and orthotics. And part of what we do for our care coordination is we call it a pre-visit. So each week, representatives from each of the services that I just stated, they prepare the clinics that will be seen in their clinics to help identify any anticipated patient needs. And then any anticipated needs or any concerns are then sent forward in a confidential manner to that core team that I had just stated, so that we are all kind of on the same page with any anticipated needs, and we can help streamline services when the patient arrives in clinic. We do have, I'm not sure if you guys are familiar with our passport. We have something called a passport that all of our patients receive while they're in our clinic. And this is a one-page document. It's a paper copy that travels around with the family. And so as they travel amongst the different teams and the different providers, it's kind of a quickie way for us to write what their follow-up is from the perspective of each of the providers. And so the family has a game plan, and they know what the follow-up is going to be of each team member as they travel about their day through clinic, since it is a busy clinic with a lot of different people that they see. And then our post visit. So at the completion of each provider visit in our Spina Bifida clinic, a comprehensive exam note is generated by each provider, and then that note is sent to the patient's primary care physician. And then individual phone calls with the primary care physician are completed by our care coordination team on an as-needed basis. And then our care coordination team, we follow up on all components of care, including our medical testing, scheduling appointments, obtaining results, and communicating results between the Spina Bifida providing team, the PCP, and the patient's family. And then our ongoing, so the other thing for the triage portion of the bullet point triage portion, so our care coordination team, we actually triage all Spina Bifida related phone calls and messages, and we collect all relevant medical, social, and educational information, and then we disseminate those messages off to the appropriate Spina Bifida team member. And so for us, it helps having that centralized kind of place for families to call. They know the one number that they can always get through to, and then we can help them navigate through their needs after talking with them. And then the other bullet point, so the urgent and emergent calls that are taken during non-business hours, those are handled by the appropriate on-call providing team. And then the on-call providing team then contacts our Spina Bifida, the care coordination team, for their appropriate follow-up. And we also make sure all of our families, we give it to them every time they're in clinic. They probably have this document 900 times, but we would rather give it every time than not enough. But all of our families are given a full list of contact information with all of our phone numbers, fax information for our urology department, neurosurgery department, our care coordination team, orthotic needs. They have a comprehensive list of all contact information that's needed.
Thanks, Colleen.
Yeah, thank you.
So the change that we made in the second year, because we had originally said there had to be a person that was designated the care coordinator. So what we added in this first paragraph, if more than one person is named as a care coordinator, which I think is the case at Lurie, just describe the roles of each person. Because anyway, so when we get applications, we look at them, and if we don't quite get it, we ask you, it might be annoying, but we say, well, help us understand this. And the other challenging thing was, what's that? I missed something. Did I miss something?
No.
Okay. Is that we asked that there be a plan for interprofessional care coordination training using a curriculum. So, and we don't prescribe that curriculum. There are several that are out there. Some institutions have, I think at Cook, you have your own plan, Courtney, that you do for care coordination for interprofessional training. But anyway, and you just have to have the plan to do it within the next year. You don't have to have done it or be ready to apply. Okay.
Can I make
So
one comment, Judy? Can I just,
Yes.
I'm so impressed with that model that was just discussed. I would just add, as a diehard clinician, that your commitment to care coordination and the non-medical piece of this is key. It is so important to promote and support the social part and all of that. I mean, I was taking notes while you were talking. I mean, there's a lot that we all can learn from each other. And I really applaud and I marvel at that you can support all of that, because just in watching these folks, man, the medical part is important, but the social part's where it all seems to fall apart.
Right. Thanks, Jeff. Eileen, Standard 6.
So, hi everyone, I'm Eileen Sherburne. I'm at Children's Wisconsin, and I am the PI, or going to be the PI for the Spina Bifida grant. And I think that obviously the grant application and the Spina Bifida clinic care partner standards really integrate with each other. So that's a big bonus. But I do know that there are a lot of programs that don't participate in the registry, but have been designated as a clinic care partner. So that's been great. In looking at this standard 6 that for promoting knowledge of the care of people with spina bifida or promoting the improvement to care, I think that it is a wide open standard to be able to easily address, honestly, because I think that no matter where you are, you're always going to be responsible for some kind of quality improvement for any program that you're working in. And for what we used for our application, it was about a study that a medical student was doing with the neurosurgeon who's the program director. And I used that as the example, but there were certainly plenty of other opportunities for, I went the QI route because that just was something that was easier for me to address when we first started doing this application. Oh, and I just wanted to say that with the application, Judy, you were really helpful to be able to make sure I was getting all those standards addressed. So thank you for that. I think that the program gives us lots of opportunities for either research or quality improvement. For myself, some of the simpler ways to find areas to work on were simply by reading documentation and trying to standardize documentation. Always keeping your hands in the pot of data for the registry. If you participate in the registry, to look at trends and just issues with data that way. I had a mother ask me or tell me that her children who were adopted from China were different than the kind of general population of native-born children with spina bifida. So we actually analyzed a small group of kids who were adopted and are looking at. We put together a DAP for the bigger aggregate population to look at how kids who are adopted differ from native-born children with spina bifida. Some other things, oh, I know. So another thing with the QI and research is we also have a program meeting quarterly, and it's getting each discipline to think about something that they want to improve within their program. So I really try and encourage them to think of the idea, and then I said, I'll do all the work for you, or I'll set it up for you, however you want to do it, but let's try and get something specific to your discipline as well. So there's plenty of places to find ideas. One of the things I recognized in documentation is the neurosurgery team, they always do teaching. So, and they document what they've taught, particularly about shunt malfunction. So one of the things I encouraged one of the PAs to look at was doing a teach back. And because there's something in the literature about how, if there's one thing kids don't know, it's about how their shunt works for a long period of time. That was in some paper that came out through the CDC. But, you know, how well do they remember that education? So doing a teach back. So that was something simpler also. We're doing one of the urology nurse practitioners is doing a mentorship program. So I'm kind of helping her set that up so that it can be a little bit more structured and we can get some good information out of it to share. And let's see, so provide written evidence. And I think that, or aim of the QI project, again, it's pretty honestly simple to do a simple QI project or even looking at retrospective documentation or data for your program. And then getting your team members involved shouldn't be an issue either. So do people agree with me that you can usually get people involved and that, you know, looking for QI projects isn't real difficult within your program, right? Yeah. And also, I think that this kind of thing helps us maintain accountability, not only to the clinic care partner program, but to obviously to our own programs as well.
And SBA
Anything
looks
else,
forward.
Judy? Oh, and then, sorry, I just wanted to mention promoting knowledge. I know a lot of programs also do educational programs for families and other clinicians. And we're kind of in the midst of trying to put together a webinar for families and clinicians. So it's that kind of thing that can promote general knowledge, doing education for other staff members. I did an education program with one of the urology nurses to the inpatient nurses on our neuro rehab unit, which is where a lot of the kids with spina bifida go if they have inpatient needs. So it's that kind of thing that you can document for promoting knowledge too.
Thanks, Eileen. And SBA looks forward to hearing the results of these studies, and we ask for that in the annual reports from partners. Any questions?
Thank you.
Thank you, Eileen. Paula, standard 7. Uh-oh, we have Paula.
I think she's muted.
You're muted.
Paula,
Okay.
you're muted. There you go.
Got it. Thank you.
Okay. The clinic has or will be working to establish a relationship with the department where spina bifida diagnoses are made. The relationship will include consultation with the family receiving the diagnosis in a standardized way. So we have developed over the years, 7 years ago, we took our prenatal diagnostic program that was headed by neurosurgery and myself. And we worked with the MFMs from the University of Utah and from Intermountain Healthcare. And with that process, we were eventually able to develop a fetal care center. And the fetal care center is open to multiple diagnoses. The referrals come from MFMs in the Intermountain area. And if the referral is related to a neural tube defect, then our neurosurgeon and the NP coordinator of the Spina Bifida Clinic are notified through the fetal center, and we begin the counseling process with the use of a fetal MRI, and have a algorithm if the couple are have met criteria for fetal surgery and want to go have fetal surgery. We now offer it here, open intervention, but some families elect to go elsewhere for fetoscopic. And so that's part of our algorithm. If they have not met criteria for fetal surgery or do not want fetal surgery, then we provide them a counseling session regarding embryology, interventions, and review a roadmap of care through the first 5 years of an infant's life, focusing on delivery, neonatal intervention, and then what happens through the clinic program for the next 5 years. If they are candidates and want to go outside of our system for intervention, we provide them the information to do that. If they want to seek in utero surgery through our center, then we connect them with the intervention team, and also during that process provide them information regarding spina bifida, embryology, and long-term management. When the infant is born, there's immediate pop-up, whether it's been fetal surgery or we're looking toward postnatal surgery, then that pop-up contacts the nurse practitioner, coordinator, and neurosurgery. And we have a whole pre-op and post-op plan that goes into the EMR and is accessed immediately. So we see that as our program's initial contact with the family, and there's a consistent intervention from prenatal diagnosis throughout the child's life. It's a program that has grown over the last 7 years and is pretty much now where we believe it will be, and is very ingrained in our Spina Bifida program.
Thank you, Paula. And standard 7, Denise?
Okay, so I have the patient advisory committee. And I'm just going to talk about how we started ours. Basically, our patient advisory
Denise?
committee.
Denise,
Can you hear me?
well,
No, I'm not muted.
it's crackly.
Is it? Okay, hold on. Let me see if I can do this.
Try now. It's not working.
So now you are muted, Denise.
I don't know who wrote that. Okay, Denise, you keep working on it. We're going to go to standard 9, okay? And then come back because we need to talk about your standard. Okay, was that you, Shannon?
Yes, it is.
Thank you. All right, Shannon is standard 9.
Hi, I'm Shannon. I'm the Adult Transition Care Coordinator and Social Worker for the Spina Bifida program at Arnold Palmer Hospital for Children at Orlando Health. And Standard 9 says it's the clinic's program for transition, preparation, and execution is documented within 1 year of this application. And so this was a really great way for us to kind of formalize what we were already doing. As the adult transition coordinator, it's kind of my job to not only provide the resources and the knowledge and the skills to transition these patients from a pediatric model of care to the adult world, but it is also to coordinate and collaborate with the adult providers. So this is obviously not just with me, but it's with our entire multidisciplinary pediatric team. But this standard was actually great for us to kind of hone in and say, okay, we have to actually get some things formalized. So I can kind of break up our approach to Standard 9 in kind of 3 ways. The first one being that you have to have, or that we had to have, administrative support. That was like the first most important thing, to have our administration to say, look, we support you in this. We can't transfer these patients to within our system to the adult care if we don't have the administrative support and our physician champions. So we identified those people, and we have some both pediatric and adult physician champions that I work closely with. But the other piece was to actually describe what the process was, like what actually happened from the minute we start talking about transition to the actual moment of transfer. And that was utilized by implementing the 6 core elements of healthcare transition, which really was what we were trying to focus on more about, like, okay, we're doing all of these things, but how does this fit into the 6 core elements of healthcare transition? So we obviously developed a policy. So we drafted a policy, and then we had collaboration and input from our urologist, our neurosurgeon, all of the disciplines that see our patients on the pediatric clinic. We had input on the policy, and then the policy was then given to our administration for actual approval. So we have an official transition policy, which basically discusses that we will see the patients from 0 to age 21, and it breaks down to say, like, at the age of 21 is when you will be transferred to the adult practice, that you will have support in transition. We're not going to, throw you to the wolves. We're going to actually, work alongside your family and your support systems. But then it also, in that policy, we'll talk about like when the actual age of transition is. So we highlight that transition starts at age 12. And then and we also highlight within the policy that age 26 is actually when patients become actual adults, typically when they age out of their parents' health insurance. So we developed the policy, and then also to really focus in on goal setting. So transition, for at least from my standpoint, is not just about coordinating the actual care that you're going to have these patients go to, but it's providing the preparation and the skills and providing the knowledge so that these patients are ready to transition and to transfer. So starting at age 12 is when I give the transition readiness assessment. And then at age 16 is when we actually start goal setting. So I say, okay, at age 16, I say, okay, well, for the last 3 years, you've put down on your transition readiness assessment that you want to learn how to make your own doctor's appointments. So now let's do that. And when the next time I see you, let's learn to do this on your own. And so that then they start to do like a one-on-one with me for coaching. So again, I was doing that before, but now that we were able to kind of put it down on paper and to say, okay, at age 12, we start transition. At age 16, we start a care plan. And then at 21, we integrate to adult providers. This is all during this time, we're talking about the insurance issues and guardianship, supported decision-making, things of that nature. And then we had to make sure that we had like what I call landing spots for our patients. So the goal is always to try to keep our patients within our Orlando health system. So what happens is that after the patient ages out at 21, they go to physical medicine and rehabilitation. We have an excellent physical medicine rehabilitation specialist who sees them. And then a new development, I guess, that has happened since we got this application was the development of the complex care and transition program, which is run by our medical director, Dr. Kristen Farias, who is a med peds physician. And that is from a primary care standpoint, where I'm now funneling our patients into that clinic so that we can actually implement the 6 core elements in a much more standard and formalized way. So again, it was for us, it was kind of just putting on paper what we were already doing, because we'd already had, some of our adult counterparts and the teaching and the self-management and the coaching and the goal setting, but we had to actually just put check marks and set times and put markers on it. So now we have a much more formalized process on how to transition and transfer our patients. I don't know if that helps.
It does, Shannon, and just to underline, to apply, you need to have a transition policy. So, and a plan to implement it. You don't have to be as far along as like Shannon just described, but to have a policy that you put your plan on paper, just like you said, Shannon, so that, and I think, Jeffrey, you want to say something? Because I know y'all have worked in this a lot.
Kirsten, yeah, no, it's great, Shannon. That's an awesome plan. The clinic that you talked about with the MedPeds person, Dr. Farias, is that solely spina bifida, or is it other complex medical diagnoses as well?
Nope, that's other complex medical diagnoses. However, I was a part of a project with her where we got, where we were actually developing like curricula, and we got a significant amount of funding for that. So our patients with spina bifida, I don't want to say they take, specialized treatment, but I definitely try to funnel the majority of our patients to that clinic and PM&R, but it isn't just for patients with spina bifida.
Nearly identical model here. So two centers wrestling with the same problem, coming up with this very similar MedPeds-based medical home
And that's the goal.
transition. Because that medical home piece appears to be crucial, because adult primary providers are as intimidated as anyone else.
Right.
Wrestling with the complexities of these, by definition, medically complex kids. So that's awesome.
Thanks. Thank you, Shannon. And I think Denise is on the phone. Are you there?
Can you hear me?
Yes.
Okay,
Yes.
can you hear me?
All right,
Sorry,
yes.
I
Thank you, Denise.
left my work laptop at home, so I'm working off my home one, and it just goes slower. So I apologize. So my standard was standard 8 with the patient advisory committee, and it is to convey we were supposed to convene within 1 year of this application, and meets regularly with the support of the clinic and advise the clinic of patient family experiences and improvement opportunities. It should represent ethnic diversity, geographic distribution, and treatment modalities. So we actually have, I'm happy to report, our first meeting coming up on October 27th. And as of right now, we have 11 members and 3 staff members. We had a meeting with Judy earlier this week with some other Coordination Academy individuals, and I shared about how the higher ups wanted us to just have 10 people. It would be Zoom, and it was to be 5 patients or family members and then 5 staff members. But I did not like that, because I wanted the patients to override us, meaning it's not about us. This is their time to tell us what they like, what they don't like. And so we went toward 15 and said that 10 to 12 would be patients and family members, and then, or caregivers, and then the rest would be staff. Right now for our staff, I have myself, which I'm the only social worker. And then we have Jolene Keller, who is our nurse coordinator. And then we have the medical director, Dr. Elias Rizek, who will be part of it. And then we have the staff, the other patients and family members. And I tried to look at genders. I did different nationalities. I did whether adults, if they lived at home or they lived on their own. And we tried to get a wide variety. Now we have patients at Hershey Med anywhere from, we were just talking about this today, we actually have someone from Montana, and we have someone all the way down to Florida. So we have a lot of different patients, and our patients go from birth to cradle to death. So we try to get a whole different variety of individuals. And what I did was call them up. We sat down as a team, and we picked so many members, and we actually screened them through risk, because we wanted people to be as honest as possible, but we didn't want this to be a complaint session. We wanted this to be educational, and we also wanted to be productive. So everybody we looked at passed the inspection, I guess you could say. And what I did was call each one of them, explain to them what was going on. And before that, I had sent them a letter saying you were chosen to be picked to be part of this new committee. We're excited. And I shared with them our objective guidelines. And the objective guidelines I really based off of Children's Mercy gave us theirs, which was a blessing. And we have a bunch of other PFAC in the Hershey Medical Center. So I got a lot of information from them. So it was really, really helpful to make the guidelines and kind of know what to start from, because it was hard to start from scratch. So I sent that to them, went over it with them. They said yay or nay if they wanted to be a part of it. We had 2 nays, which I said, that's totally fine. I'd rather you be honest and let me know instead of not being able to come to the meetings and filling a spot. And they said, maybe later down the road, no problem. So after that, they have to sign. We have forms that need to be signed through the Hershey Medical Center, and it's a confidentiality form, and it is a media consent form, just in case we go on to any kind of social media, which I don't foresee that happening anytime soon. But what they did was they are to sign that. I sent everything to them in a self-addressed envelope. I asked them to please sign it, please send it back to me. And then that was really the qualifications. It was, they asked a lot of questions like, do I need to come to every meeting? What is the purpose of this meeting? Who's part of it? And again, I stressed with them, this is your meeting. And it's really because we want to continue to be patient-centered focused. So this is the whole point of this meeting. And right now we're going to meet every 3 months, so quarterly. And some people said, I can't do that. And I said, that's no problem. And we said, we would revisit it. This is, going to be a work in progress. And we'd revisit it and see what people liked. And when we had our meeting earlier this week, I stressed, one of my concerns and one of my goals was to get somebody from all our departments, meaning urology, all of our, because we're multidisciplinary, urology, neurosurgery, orthopedics, orthopedics/physiatry. And we only have neurosurgery, but one of the other members had told me what they do. Yeah. One of the other members had told me what they do is they invite other staff members to come in and to present every, like maybe 5 minutes or 10 minutes every, maybe once a year or twice a year. So they're not dedicating themselves to every 3 months. So I thought that was a good idea. So I'll take that back and bring that up with the other faculty and staff and see if they'd be willing to talk about that. But so right now we're just really, just going for it on the 27th and just seeing how it goes. And hopefully, I don't foresee this dying because a lot of our patients were very appreciative, and the caregivers and parents were very appreciative for us even wanting to do something like this. And we have it actually kills 2 birds with 1 stone, because we have a grant from the state is how we're funded. And one of the criteria now was to have a patient advisory council. So it worked out perfectly, but I'm just excited to give them a voice, because they never feel like they're being heard. And they were just extremely appreciative. So, that's pretty much all, but I'll give anybody an update later on after the first one.
Great. Thank you, Denise, and thanks for persevering on the sound.
No problem. Thank you.
All right, standard 10, Courtney. Courtney's got a bunch of people coming for dinner any moment now.
Oh, they're here. No, it's okay. I'm surprised you can't hear it. No, that's all right. So I feel like I got the easy, most fun standard to talk about. So standard 10 is really just having people from our clinic have an active relationship with SBA. And so being able to do at least 2 of kind of those activities that are on that list per year. And so some of the things that we've done, we actually have a really active SBA local chapter. It's SBA&T, so Spina Bifida Association of North Texas. I have been on the board, I think I'm in year 3. And so that's been super helpful to get integrated really into our community. And then last year, 2 of my colleagues, so one of our urologists, Dr. Kay, and our PM&R doc, Dr. Taylor, both joined me in joining the board. So we have quite a bit of representation from our hospital, which is really great. As a clinic, we try to get people together to do the walk-in roll. Our SBA&T has education days once a year in February. And so they typically ask at least one person from our team, if not more than one person, to talk about, whatever it is that the families and patients want to hear about. So a couple of years ago, I gave a talk on depression. Last year, my colleague, Blake Palmer, one of the urologists, gave a talk on bowel management. And Kristen Taylor gave a talk on local resources in the community. I'm just looking, I've attended the clinical care meeting, the original one a couple years ago, the initial one. We give a lot of the SBA resources. I love the information sheets for our families, especially kind of in the beginning. And we have 40% of our families request a Spanish interpreter. And so having those information sheets in Spanish is super helpful as well. And we had started, our hospital wanted us to create our own information sheets. And it was like, why in the world would we start over and reinvent what people have already done? And we know it works and we know it's helpful. The listserv for spina bifida healthcare professionals is obviously a really easy thing to join. And then this year, I guess 2 years ago, I joined the Science and Research Committee for SBA. And so this year I'm helping Kathy on mental health guidelines, and then the updating of the mental health guidelines and updating of the family functioning. So it's the reason I love this piece of my job, and I don't know if I said, I'm a psychologist at Cook Children's in Fort Worth in urology, is that it's super fun to see our kids and families outside of the clinic. Like, our patients think it's so funny to see our doctors, running around and in t-shirts, and we do like a little teen retreat and stuff for some of our patients, and having their, surgeon as the counselor sleeping in their bunk. And it's really nice because we really get to know our patients on kind of a more intimate, personal level. Yeah. So it's definitely the fun standard.
I couldn't find my face to unmute me. Thank you, Courtney. Thank you, everybody. Bobby, do you have any questions or comments, or does anybody have any additional comments?
No, I don't. This has been helpful. It's, the areas where we are lacking are areas that are the whole medical, we have a surgical medical director, and we're very collaborative with the PM&R group, as well as developmental medicine and stuff, but we don't have them as part of, as a dedicated part of our clinic. They don't have the wherewithal in their schedules at this point to give us someone to be an actual attendant, if you will, in the clinic. So, funding is frustrating. So it just is.
Right. I know y'all been working on it a long time too.
Yes. Yes.
Jeff, any thoughts about that?
That's the big, challenge, right? So I'm in the pediatric section of the AANS, and Brad Weprin and I were tasked with trying to work on a transition, piece for the section, so that all the pediatric neurosurgeons that belong to the section can gain from mutual experience. And I was fervently writing when Shannon was talking, trying to learn from her and from everybody else who does this. as various people were talking, I was thinking, how's everybody paying for this? Because that's the hard part, right? And most of it is rolled into, at least for this is purely observation, is rolled into some creative funding absorbed by the hospitals and people working beyond their job description. That's kind of what it seems to be mostly, right? Please
Yes.
I would agree wholeheartedly with you, Dr.
You get, I mean, this disease is loaded with misery and suffering. So you get good people exposed to this disease and it's inherently motivated, right? If you're motivated to help suffering people, I mean, this disease is ground zero, right? Everything we do from day one until the day we lose these folks, they graduate, whatever it may be, is at some level palliative, right? We cure very few things with spina bifida. We treat symptoms, we support them, we love on them, we show them all the good things that we can, but we don't fix it. And so everybody ends up motivated and works beyond their calling. That's not a very fulfilling thing, but I think that's the observation of where it's at right now. So I'll close my comment to say, I think the burden is on us to show value of what we're doing. And the way we do that is that we show that this quality of care that's being provided by care coordination, by social programs and people outside of the hospital carries over into better quality metrics, fewer needs for emergency room visits, fewer fatalities, fewer unexpected visits to the emergency room, and whatever else the metrics are. And the metrics are tricky because the payers don't want to pay now. You can show them that they'll save $5 down line for every dollar that they spend now, but they still got to spend $1 now. And the system doesn't always have that future time preference built into it. Those are my comments.
Thank you.
I would agree with that. And to just prove, a lot of what we've had to do is kind of prove that what we're doing is a money saver. It might not be an immediate money maker right away, but it's going to be a money saver in the end. But then there lies the problem of how you show that.
Yeah. And the paradox is so much in the current system is focused on a short timeline vis-a-vis fiscal issues, right? What's your budget for 2021? What's your budget for 2022? Well, it's wonderful. You're going to save money in 23 and through 25, but you don't realize that in the short timeline fiscal analysis. And
Well, Bobby,
there probably is a role for SBA to advocate these positions. Just, you guys can kind of say them without even necessarily having to evidence-base them, right? That there's consensus of opinion that this is a problem. There's consensus of opinion that this results in cost savings, but the current system doesn't necessarily emphasize that. But SBA is aware of these problems. Even just a general support statement like that is something we can bring back to hospital decision makers and policy makers.
Right. Thank you. And Bobby, reach out to any of us as you go forward. And I know that we can't twist that person's arm or anybody's arm, but we're interested in getting all our clinics in this fold.
Oh, absolutely. Thank you.
Yeah. And thanks, everybody. I really appreciate this. We've recorded it. It'll be available to people and we'll have it on our website, right, Juanita?
I don't know if we'll have this particular meeting on our website, but we will definitely send you the recording and maybe we can find another way to share it as well.
Okay.
Or actually, I'm sorry, Judy, you're right. We could probably put it on our website as well for anybody to access whenever.
Right. Yeah.
So, yeah.
People who are wondering about some of the standards.
Thanks to everyone. I learned from everyone who spoke. It was really interesting. Thank you all.
Yeah.
Yes,
Yeah.
thank you.
all.
Take care.
Thank you. Thank you. Thank you.
Thank you, everybody.
Bye.
Bye-bye.
Bye-bye.
Thank you.